Thank you, panelists. As we head into our third panel, I wanted to mention that Admiral Winnefeld expresses his regrets. Unfortunately, he had some flight delays traveling to DC, so he was unable to join us today. But we now turn to our third panel, which focuses on tackling the epidemic in the community. I wanted to call up Dr. Dana Hunt, who will introduce our last panel. Thank you.
Hello, everyone. I'd like to invite Dr. Gastfriend and Dr. George up to, and I'm sorry Admiral Winnefeld couldn't make it, but we'll carry on. So I first wanted to have you each have the opportunity to introduce yourselves and talk a little bit about what you do before we start the discussion. David?
So I'm David Gastfriend. I'm an addiction psychiatrist. I basically have decided to focus on research that leads to change in practice. And there are three areas that I've delved into deeply. The first is in development of assessment software for determining which treatments in addiction the patient needs at the current moment, and a decision algorithm to help treatment providers assign that patient and potentially reform the prior authorization and utilization review process. And that's the criteria of the American Society of Addiction Medicine, or the ASAM criteria. The second area is in pharmacotherapy. You've heard about agonists, agents like methadone, buprenorphine is the second. I got an opportunity to work on a blocker, which is the opposite mechanism. It takes naltrexone, which is a once-a-day medicine, and I got to work on a month-long version of that, so one injection that blocks all the opioid receptors in the brain for a month, and that's called Vivitrol. So I worked on that for about a decade. Then the third area is we have a superb treatment that's the best research treatment we have in the field of addiction medicine, and almost nobody uses it. It's called contingency management. It's financial rewards for retention, motivation, and abstinence. And there are obstacles to that, and I've decided to focus on solving those with technology, taking the burdens of effort out of the hands of the clinician, putting it into the hands of the patient. And so I have recently been working on a project to make that a scalable technology for routine use in clinical care.
All right, and I am Jittu George. I am a practicing pharmacist. I've been a pharmacist for 12 years now. And my first exposure to the opioid epidemic, it was about 8 years ago when a family member was a victim. So I grew up in Philadelphia, and Philadelphia is at the center of the crisis. We have we've been at the top for quite a while now, and being a pharmacist and being in a retail setting, my early days were spent in working for a chain pharmacy. So you have an expectation of what a pharmacist would do coming out of college, and it's not what you expect it to be. You essentially end up being a pill counter, and you have numbers that you have to meet. I did that for 3 years, and after that got introduced to Pathways to Housing, which is a Housing First homeless program. And 3 years ago we opened a pharmacy in North Philadelphia that now practices based on collaborative care. We manage close to 300 patients for Pathways to Housing. All of them were who were previously homeless. About 10% of them suffer from opioid disorders. All of them have psychological problems. They're all Pathways provides primary care, psychiatric care, and also your Suboxone and your naltrexone and Vivitrol program. What we do is we manage their medication treatment options for these patients who suffer from the crisis. And over the course of the last 3 years, we have progressed. So we started off not knowing how to address the problem, but what I can stress on is when we talk about the importance of different practitioners working together, a lot of times pharmacy is usually forgotten, and that's because a lot of the practices that we have now don't have pharmacy integrated into them. It's different if you have, if you work in one of the larger settings, your Thomas Jefferson, Philadelphia, or University of Pennsylvania. But a lot of the smaller nonprofits, a lot of the smaller settings don't have a pharmacy care integrated into it, and we've been trying to change that. We've been doing a lot of packaging services for these patients, recommending breaking down of opioids into smaller portions, so this way patients don't have your entire 60 or 90 or 120 at a time. And even for Suboxone, breaking it down into weekly treatment options, the pharmacists control how many each patients get. And when we realized that as a working model, we started approaching more facilities. So we work with 4 different facilities now. We have 3 pharmacies. We have a proposed medical marijuana dispensary we're working on. I'm a huge supporter of that and its potential to help alleviate pain and possibly help us with some of the crisis that we have now. And I'm here to share a pharmacist's perspective.
Thank you. So there, as someone mentioned before, the epidemic has been in cycles over many years. I started my career in Philadelphia working on heroin. And there have been decades of work on different community-based treatments for substance abuse and opiate addiction in particular. Does this current crisis present a different issue, a different problem for community-based care?
Why don't you start with?
Oh, yeah, sure. Well, I always like to go back to thinking about when we had an issue with insurances. So we went through a phase about, I would say, 5 to 6 years ago where people were underinsured. And then we established easier access to insurance care. But I think one of the biggest issues that we forgot to address was how well insurance coverage truly is. And I see it all the time. So we have patients coming in for their Suboxone prescriptions. There is usually at least a week to 2 weeks lag time between when I can get them, when they are prescribed this medication, to when I can truly get them their prescription. And don't get me wrong, there's some fantastic insurances out there, but the part of Philadelphia that I operate out of, people, their annual income is less than $10,000. They live below poverty level. As some of the previous panelists were talking about, we have grandmothers raising their grandchildren. The parents are incarcerated. So I think the problem is we went through a phase where insurances were covering too much opioids. So a prescriber would write for 120 or 180 of your oxycodones, and insurances were covered without a question. And that happened for a good 3-4 years, and patients were getting used to the easiness of having access to these opioids. And then when we started understanding the nature of the problem and where things were wrong, they did the complete opposite. So now, to get the pain medications that these patients were on previously, you have to jump through a lot of hoops. There's, the number of times patients who truly need it who don't end up getting these opioids. It's a shame, and we see it every day. And not just for opioids, for Suboxone, some of your medication, MAT treatment options. Forget about Vivitrol. You try to get Vivitrol through one of the Medicaid plans. It's just a shame. We get continual rejections, and it's just not the way it should be. So I think it's changing. Mm-hmm. It's changed, and the system, I think it's not the most efficient to treat the problem.
David?
Yeah, I think this is a very different demographic process underway in our lifetime. It's not the first time in our history that our country's been through something like this. At the turn of the 1900s into the early 1920s, we had an epidemic in this country with opioids and related compounds where distribution was massive, and we had an entire population that was addicted. And healthcare, medical education had to undergo dramatic reform. So it was a systematic transition. And it reformed medical schools, it introduced prohibition, it disrupted our economy, criminal justice, and we overreacted. We're going to, unfortunately, I think, go through the same process now. It's actually, the prospects could be better now because the science is very good. We have the tools, we have an understanding. The commander was talking about people coming out of jail after 8 months and going back, losing their tolerance and overdosing because they used the same number of bags of heroin as before. It's even worse than that. We have a science with animals that teaches us if you take a drug away from an animal for a stretch of time that they were used to self-administering by pressing a lever to get that injected into their brain, and then you give them access to it again. Now they've lost any detox, withdrawal symptoms. They're back to normal physiologically. But when they get access to that drug, as you do when you get out of prison, they press the lever much, much faster than they did before you took it away from them. So we have people coming out of prison, and we have made them more addicted. And they've lost their tolerance. As a result, the death rates, depending on which study you look at, are 12 times that of the general population to over 100 times the death rate of the general population. We are programming people's brain circuitry to kill themselves. The whole prescribing epidemic of, the pain is the 5th vital sign. Your pain should be measured on a scale of 0 to 10 is preposterous because it insinuates that every patient's pain should be 0. Well, pain is the body's way of telling the brain to take care of itself, to protect itself so it can heal. And if you eliminate pain, you eliminate a normal, needed physiologic signal. So we have what programmers call systematic error. And that means the entire system needs to undergo reform. Not just, I absolutely agree with what you're saying about access to MAT, the medications and addiction treatment. But we need to defrag a fragmented healthcare system. And I think what Darren was saying about the funding mechanism, payment for prospective care, is a change that is beneficial and will take a lot of work because we don't really have the data to know how to plan for those funding mechanisms. So all we can do right now is really experiment. But this epidemic is going to require that we transform a whole variety of systems, healthcare, criminal justice, payment, and find ways to integrate the thinking across all of them.
So that sort of prompts my next question, which what seemed to be the most promising and the most effective of these sort of integrated or community-based approaches?
Well, I'll give you 2 ideas. One, the hub and spoke model that Vermont has developed, where specialty central services assess and initiate treatment and stabilize patients with addictions, with the opioid use disorder. And then once they're stabilized, transfer their care primarily to primary care. So that's a distributive model, and yet there is support for the primary care systems to adopt the opioid treatment that the specialty center has initiated and to stick with it and to have peer mentoring back and forth when the patient continues to have flares, gets into trouble, needs more services. So that's something that can easily be disseminated nationwide. And the federally qualified health systems, services can, there are thousands of these across the country, they could easily adopt that. The second idea is for state Medicaids and the single state agencies for substance use disorders to integrate their efforts. The American Society of Addiction Medicine, which I work with, has gone into states, met with both leaders in the room, the state substance abuse director and the Medicaid director, and said, we could standardize the assessment of the patient throughout your state's publicly funded programs. There's a tool that can guide even the novice clinician. We're increasing manpower. There's tremendous turnover of manpower in these programs. Let's get them all operating at a high standard level. Just like if you go in for oncology evaluation anywhere in the country, you're going to get a high quality evaluation, and they'll know how to stage the cancer and the right protocols for treatment. We can do that now with the science that we have in addiction medicine. We have to get there. So the state director for substance abuse says, well, that's a wonderful system. I would love to be able to do that. But how do I get my treatment programs to use it? I can't do that. And the state Medicaid director says, oh, don't you worry about that. We can take care of that one, because they control the dollars. So it's by integrating across agencies that we can actually make these transformations.
Well, so what we do has very little innovation, but we rather implement what's out there. And just to give you an example, it's so simple, but like I was saying previously, we have patients who are on naltrexone, for example, or Narcan for that matter. So we have a collaborative agreement with the practitioners who are at Pathways to Housing, and we provide a Narcan to any patient that the pharmacist identifies as a potential drug abuser or who is in contact with one. So, you know, when we came out with Narcan, and when Pennsylvania made the availability of Narcan easily accessible to anyone who truly wanted it, it was great, but like a lot of the panelists said before, the problem is implementing or enforcing, you know, what we do with it from then on. And so what we have done is take what the resources that are already available and truly put it to use. We have a pharmacist who works solely with these facilities, and what they do is when they get a new intake for a patient who is on a medication administered treatment option, we check PDMP. It's a resource that's available to everyone, but it's not a requirement, but we make it mandatory that we do it. We have a protocol that's signed with the physicians that we work with where they have to do it, we have to do it, and that's the only way we fill a prescription for a patient. But the truth of the matter is, although it's a resource that's recommended, and a lot of the resources or the guidelines that are out there, they're still recommendations. It's not enforced. But I think what needs to happen is enforce some of what we have. And it could be simple things like that. And to be honest with you, a lot of the overprescribing, a lot of poor pain management that we have seen as pharmacists, at least in the pharmacies that I work with, in the neighborhoods that we are in, they don't come from your physicians who are you know, certified in pain management or who are under the radar of a larger corporation. It's never that way. I mean, you probably see one or two every few months, but those prescriptions are written appropriately. A lot of what we see are independent practitioners who, at some point, opted to go this route because of under reimbursement or not making sufficient you know, revenue from insurance companies for the service that they provide. But the problem is, so we see the same prescribers at least 10 times a day, the scripts walking through the door. And if I see it 10 times a day, you know, you can only imagine the number of times the other pharmacies in the area see it. So we have a DEA reporting system, and we use it frequently, but I don't think anything comes out of it. We have at least 10 urgent cares in Philadelphia, in the neighborhood that we work in. They get shut down once a month. They reopen the next. So I think the problem is, you know, I think we know the problem, but it's just that the enforcement is not done appropriately.
Can I ask you to go back a little bit to the PDMPs?
Yeah.
Is that was a system that was sort of set up to help both docs and pharmacists to use
Sure.
this. On another project that Abt has, I'm finding that some of the counties that are trying to be part of this system have no ability to use it. They don't know how to access it. Is it, you use it frequently, and is it helpful?
We use it every day. It's probably the easiest system
Maybe you could
to use.
explain to everyone
Yeah,
what PDMP is.
So as a practitioner, what you have to do, it's a prescription drug monitoring program. So as a practitioner, what you do is you create an account, submitting your DEA number, your national provider number, and every time you see a patient, the CDC recommends that the practitioner, if it's a new patient, or now I believe it's changed to every time you see a patient, you review the patient's profile using their name and date of birth, and it will tell you that if they have had another opioid from another prescriber in the previous 2 years, or whether they have had it filled elsewhere. So I think it gives you the ability to see how compliant they are. So just because a patient walked out of a prescription today, it does not mean that they had it filled today. It could be 15 days from now, and then their next appointment could be exactly 30 days from the original prescription date. So you just don't want that patient to have that 15-day surplus. Mm-hmm. So simple things like that could be prevented by using PDMP. And you know, it sounds silly, but I always use this example. So iPledge, Accutane is, you know, the iPledge program is one of the most enforced programs in the country. It's simple. So we had tons of birth defects from Accutane back in the day when it was not properly prescribed. And iPledge came into play where the prescriber has to log in, perform your pregnancy test. Patients have to log in. They have to go through education material, relearn what they learned every time, every month. The pharmacists have to log in, and they have to punch in what date they're filling the prescription, what quantity, and write an authorization number down. The deaths from Accutane is 0 today because we have a well-informed a ladder program. So you have a 3-tier system where the prescriber has to log in, the patients have to log in, the pharmacist has to log in, and it creates accountability. If the prescriber does not log in, iPledge does not authorize a pharmacist to fill it. So it essentially, you know, it essentially restricts your ability to just write prescriptions and not care about a patient or fill scripts.
I want to say something about the reason that structural change is critical for this disease. In every other disease, the illness causes a discomfort that makes each of us want to feel better. In addiction, we have a disease where the disease makes the patient, the person suffering, want to have more of the disease. Okay? Think about that. The brain's reward system has been corrupted by a chemical agent, a drug, heroin, pain pills. And the drug teaches the brain that the key to happiness, to survival, to sleep, to calm, to euphoria, is to get more drug. So that individual is not functioning as a healthy organism. They are not pursuing the survival of the species. They are not pursuing self-preservation. They are pursuing getting more drug, protecting the supply to the drug, hiding the appearance of using drugs, making their use covert. The reward system in the brain is deeper in the actual physical brain than the cortex, the thinking brain. As a result, it is not available to consciousness. It's a chemically responding reflex center. It's what we respond with when we're hungry and we need food, when we're thirsty and we need water, when we're old enough to procreate and we want sex. It recruits the big thinking cortex, all that white matter, all that gray matter. It recruits all that gray matter to do its bidding. And we have a lot of cortex, so we can think of lots of different ways to achieve that goal. But once that reward system is tuned to getting more drug, it recruits the rest of the brain to find ways to get the drug. Now, the problem with that is our healthcare system, our insurance system, is all built on the premise that the individual wants self-preservation, wants to have more comfort and health. But people with addictions don't want that. They're not driven towards that. Consciously they are, but their drive system is more primitive and therefore more powerful in terms of driving behavior. So we need a system that integrates the information of the PDMP and the funding mechanism and the utilization review of the insurers all into a model that is guided by this science that addresses this tendency of the individual with addiction to not be driven to get healthier.
I would also say, back to your point, that system, your integrated physical system, is actually critical in this. But what you started with when you introduced yourself and what you did was also the need to integrate the community and the socioeconomic system of the folks that you're dealing with. People who are homeless, people who don't have jobs, all of those things are feeding into this. Could you talk a little bit more about the project that you were talking about?
Yeah, absolutely. And pathways to housing, it's probably one of the best models that I've seen when it comes to working with the working with the homeless population. So it's a housing first model. So what they do is rather than treating the problem before you house a patient, they house the patient first. Mm-hmm. They surround the patient with resources that are essential to the success of some of these treatment options. And I completely agree. What is the point in taking a patient to an emergency room and treating them for 2 or 3 days worth of care and evaluating them after that, only for them to go back to homelessness? Okay. It just simply does not make sense. So what they do is they house the patients first, and then their physicians, psychiatrists evaluate these patients, and based on whether they require medication administration treatment options or not, then the physicians usually have a conversation with the pharmacist to determine what the most appropriate delivery method is. And the method of delivery, I know one of the previous panelists, I think you were talking about the problems with the delivery of these options, and I think that is one of the biggest problems we've seen. A lot of these patients don't have the money to afford their copays, right? It could be $1. I have it, but they don't, right? And a lot of the Suboxones and Vivitrol said it costs a lot more. So that's an issue we've had with compliance and the final delivery of these options. But being a part of a program such as that helps overcome that issue. They have the funding to monitor these patients, to ensure that the patients truly receive what medications they need. And it's just not your primary care, your psychiatric care. There's a heavy focus on supplementing that with physical therapy and alternate medicine. So there is a heavy-duty counseling program that they implemented 2 years ago, where we have physician enabled and pharmacist enabled counseling on Suboxone, on your nicotine replacement regimen. So I think being a part of a program such as that, that's truly, and I've worked with some of the worst programs out there. We have several nonprofit organizations in Philadelphia that abuse the system, and we have people coming out of the prison. It's easy to get a nonprofit status if you truly know what you're doing, and then you get a nonprofit status, and you have patients who are crammed into one small townhouse. You have 25, 30 patients, and they all go to the same physician, and they all get the same prescription. At a certain point, you start to question it. they all look like photocopies. It's the exact same antipsychotic, antidepressant, and you're naproxen, oxycodone, Flexeril. That's not how it should be done. So I think what needs to be done is more funding for organizations such as Pathways or Your Prevention Point in Philadelphia that are trying to do good and provide treatment options in a better manner rather than these smaller, not well-run. I think that needs to happen.
So what is your experience in trying to experience with communities in trying to balance the two sort of conflicting attitudes between law enforcement and, not always, and Commander, I was very happy to hear your comments, but between a law enforcement approach and a medical approach? You gave some good examples of ones in which that's probably not the best, those nonprofits, that's not the best for that client to be in there. There are a lot of people jumping into this in an illicit way. What's your experience in trying to balance the community, in the communities, those two factors?
Sure. Go ahead.
Well, it's a really critical thing in relation to the disease model that I laid out, because in a disease where you're not driven to necessarily start by wanting to get better, social constraints can really channel people into recovery. So if the sheriffs who are thinking about releasing drug-related offenders back into the community, if they allow in healthcare providers who can do an assessment inside the jail or prison. Now, California is releasing tens of thousands of drug-related offenders as a result of a statewide referendum a few years ago. They're getting those people evaluated in the jail in an expert fashion before they're discharged. If you can initiate medication for opioid use disorder, if they're not physically dependent, they can start on Vivitrol before they're discharged. That's been a national campaign by the manufacturer. And full disclosure, I spent 10 years working for the manufacturer, and I'm a shareholder. If you have Medicaid set up as someone leaves so that their access to services and medication, buprenorphine, is available on the first day, then you can really stabilize people not just in terms of their risk for death, but to get treatment and to get other services like housing and vocational support and child care service. And then you need a system of sanctions that is compatible with the system of treatment. So there are, for instance, DUI programs in Hawaii and South Dakota. Hawaii, it's called HOPE. In South Dakota, it's called 24/7, where if you have a violation, so you drive with alcohol in your system or with drugs, you get sent rapidly back before the judge into jail the same day or that week, and you have a prompt, measured sanction that's fitting with the behavior that is designed to coax the individual to stick with treatment. And when that is all set up in an integrated fashion, now you're defragmenting an otherwise fragmented system. And that's very conducive to helping people succeed in the longer term.
And there's a lot of good that's happened over the course of the last few years. I know we all focus on the bad, but we have gotten really far. So I have a friend who practices as a registered nurse at the Philadelphia prison, and they have a Suboxone program now. So if you need Suboxone, it is being implemented. You know, it's a slow start, but they did that on a smaller scale. The trial run, and he tells me it's had great success. So I think, you know, things of that nature, it's doing a lot.
I mean, one of the things that has been this kind of discussion is the discussion of Narcan. I just had this discussion with someone who was saying, well, it's fine to give Narcan to social workers and to all those people, but it's just going to, if you give it to people on the street, it's going to encourage people to use more. Have you hit this at all?
You know, it's Narcan is always been a you know, a controversial discussion topic. So I was involved in a conversation about it on the way into DC, and I was on the phone with a friend talking about the topic of discussion today, and he knows what Narcan is. He has Narcan, and you know, one of the we were just running through some pointers, and one of the things he was telling me was, well, you know, if you have Narcan, then that gives you more incentive to overdose.
I had this same discussion.
Yeah, so you know, in a way, if you want to think about it, yes, but if people truly want to overdose, they will overdose. I don't think Narcan is really a proponent of overdosing. And from what I hear, if you're overdosed, the last thing a patient wants is Narcan. They don't want that high to wear off, right? I've heard that at pretty much any conferences that I've been to. So I just don't think that Narcan is the reason why that's happening. The other day, I was talking to a pharmacist at Rite Aid, and she was telling me how they have at least 2 or 3 overdoses in their parking lot a month, right? And I asked her, what's the reason for that? And she was telling me, I wonder if it's because we just started carrying Narcan. You know, I just think people like parking lots.
And McDonald's.
I just think that's what it is. So you know, you should have Narcan. If you, as a pharmacist, knows that someone's overdosing in your parking lot, you should have Narcan.
But there's more. We need to structure a system of treatment and engagement into treatment that takes into account the disease. So if you see that people are having repeat overdoses, we need to have a different method of entry into the treatment world than you go to an emergency room with a Narcan reversal and you're streeted. A number of states have civil commitments, not just for mental health crises like acute psychosis or suicidality, but also for use in overdose, where you can, against the patient's wishes, coerce the patient into 3 days or 10 days of treatment in an addiction treatment facility where they get time to get their withdrawal stabilized, their craving stabilized, and then you can have the discussion of, is this something you want to deal with now, or do you want to go out there and get killed? And that's the only context in which that discussion is worth having. If you have somebody who's in the emergency room who's just undergone a reversal, they're actually in withdrawal. They can't even hear what you're saying and think about it. So as a society, we have to review this brain effect of addiction for what it is. We can't use our model of social values for human beings as independent entities and just say, well, that's how we should think of people with this disease, because the disease doesn't allow an individual to be an individual as the rest of us think of ourselves. So we really have to think much more broadly about the whole legislative process and how we utilize our laws.
So I think we're out of time. I want to thank both of you. This was a really good discussion, and I hope everyone else benefited from it also.
Thank you.